For my evidence-based practice presentation, I'm going to be speaking about deep friction massage. The procedure is rubbing back and forth at the point of greatest tenderness, perpendicular to the fibers of the tendon. On the right, you can see the procedure, which you increase in intensity, which only lasts for about 1 to 2 minutes until the sensitivity subsides. How this works: normally the tissue should not be disturbed when healing, but some stimulation is vital for tissue health, such as to move fluids or induce connective tissue repair. So deep friction massage provides a method of stimulation that is new and different to the motion that caused the injury. This is normally used by physical therapists, occupational therapists, athletic trainers, and massage therapists. For treatments, it's normally for tendon disorders, and you can see the list above. A main one that we'll be talking about is lateral epicondylitis, and the proposed benefits for these treatments is to increase blood flow, eliminate adhesions, and stimulate mechanoreceptors. This procedure is controversial in the aspect of lack of evidence and research. The first study tried treating lateral epicondylitis with many different variety of ways, and you can see those lists right there. They had 3 different sections of probably helpful, possibly helpful, and then the ones that definitely did not help the lateral epicondylitis. But the deep friction massage they thought would realign abnormal collagen fiber structure, break up the adhesions and scar tissue, and then increase healing with hyperemia. However, they found that there's no sufficient evidence to form a conclusion regarding this treatment of lateral epicondylitis. The second study looked at treating lateral epicondylitis as well, but using deep friction massage with Mills manipulation, and they applied it for 10 minutes every other day, but there's little scientific evidence on the effectiveness of deep friction massage, so they were hypothesizing that it would diminish local pain and result in better alignment of the connective tissue. The results for the study showed that the corticosteroid injection actually had better results in diminishing pain and the range of motion, but the follow-up results, which came within a year, showed that there was no significant difference between the 2 treatment groups, and so overall the study was inconclusive regarding deep friction massage. And then lastly, I looked at a study about rehabilitating the adhesive capsulitis, and there were 2 groups. The CYR group used the deep friction massage with superficial manipulation, and this happened at hourly sessions 3 times a week. And the PT group used the physical therapy modalities using hot packs, and they did this in 1-hour sessions daily. Both groups, after each session, used active stretching and pendulum exercises, and these were 40 patients between 40 and 85 years old, and they had to have had shoulder pain for at least 2 months with no trauma and a loss of active and passive shoulder motion. So the results showed that the CYR group had a higher rate of recovery than the PT group, but both groups had reduced pain and improved range of motion. However, improvements in shoulder flexion, inner and outer rotation, and the decrease in pain with motion were significantly better in the CYR group, so this study did support deep friction massage. Overall, with these studies, there's inconclusive results regarding deep friction massage and its effectiveness, but this is due mainly to the lack of evidence and research.